Bismillah ar-Rahman ar-Rahim. This is a lecture about aneurysms and dissections. An aneurysm is a localized abnormal dilation of a vascular wall or the heart. For comparison, we have here a normal blood vessel, and here we have a blood vessel that is involved by this abnormal dilation. This dilation could either involve only a segment or a part of the wall of the artery or the blood vessel, or it can involve the whole circumference of that vessel. For the types of aneurysms, we have fusiform aneurysm, saccular aneurysm, and fusiform saccular aneurysms is a combination of both types. So for comparison, here we have a cross-section through a normal arterial wall. From inside, the red layer is the intima, represents the intima. The yellow layer represents the median, and the gray one represents the adventitia. So in case of fusiform aneurysm, there is circumferential dilation in the wall that involves a part of the wall of the artery or the vascular wall. While saccular aneurysm, there is only one segment or one part of the wall has that dilation. Both types represent true aneurysms. True aneurysms are aneurysms that actually contain all three layers of the vascular wall: the intima, media, and adventitia. So it has the three layers of the vascular wall and they are intact. So to begin with, types of aneurysm include true aneurysms, in which all three layers of the arterial wall or the heart are involved by the dilation. Examples of this type of aneurysm include atherosclerotic, syphilitic, congenital aneurysms, as well as ventricular wall aneurysms that follow a transmural myocardial infarction. The second type of aneurysms is called false aneurysm, or what is also known as pseudoaneurysm. In this condition, there is a breach in the vascular wall, which leads to the formation of a hematoma, bleeding into a hematoma that communicates with the intravascular space. So this pulsating hematoma will look from outside, it will look like an aneurysm, a dilation in the wall. But actually, this is not true. This is not the case because there's a tear through the wall of the blood vessel. This blood collects within the extravascular connective tissue. Examples of those false aneurysms include ventricular wall rupture following myocardial infarction, which is contained by a pericardial adhesion. Other examples of this type of aneurysm includes any event that leads to leak from a vascular wall. For example, a leakage at the junction of a vascular graft with a natural artery. Now, according to their shape and size, aneurysms can be classified into saccular and fusiform aneurysms. Remember that the shape and the size of any aneurysm are non-specific for any disease process or any clinical manifestation. It's a pure description of the shape of that aneurysm. Saccular aneurysms are spherical outpouchings that involve only a portion of the vessel wall. Sometimes it might contain a thrombus. Fusiform aneurysms show diffuse and circumferential dilation of a long vascular segment. These aneurysms may vary in their diameter and length, and they can involve extensive portions of an artery. Now, to summarize, aneurysm is an abnormal bulge in a vessel. We have two types of aneurysms: true aneurysms and false or pseudoaneurysms. A true aneurysm is the one that contains all layers of the vascular wall, and it might have two shapes or morphologies: fusiform and saccular aneurysms. A pseudoaneurysm or a false aneurysm, on the other hand, is not a true aneurysm because it does not contain all layers of the vascular wall. Instead, there is a hole or a defect in the vascular wall through which blood is extravasating that blood vessel and forming a hematoma outside. Why are pseudoaneurysms called that way? Because when we look at the vascular wall from outside, we cannot tell which is which. We cannot tell which one of these would actually be a true aneurysm or a false aneurysm, because all of these would show up as a bulge in the vascular wall. Any blood vessel, especially arteries, as well as the heart, can be involved by aneurysms, but the most significant affection is that of the aorta. So aortic aneurysms are very important vascular diseases, and this abnormality can affect any part of the aorta. So it can affect the first part of the aorta, or the ascending part of the aorta, the aortic arch, or the thoracic part of the aorta, or the abdominal aortic segment. The most important one of these, and the most common one actually, is the abdominal aortic aneurysm. Aortic aneurysms have two very important causes or underlying mechanisms. Number one is atherosclerosis. This is actually the most common cause. The reason for development of aortic aneurysms due to atherosclerosis is that the intimal atherosclerotic plaque will lead to compression of the underlying media, and this compression will compromise nutrients and waste diffusion into and out of the arterial wall. This will lead to media degeneration and necrosis, and this will lead to weakness in the wall of the aorta. This thinning and weakening of the media of the aorta will finally lead to dilation of the aorta. The second very important mechanism of aortic aneurysm is cystic medial degeneration. We mean by that anything that leads to degeneration and weakness of the media. We have many causes, and those include trauma, congenital defects like the cases of Berry aneurysms in the brain, hereditary defects and structural components of the media, for example, Marfan disease, infectious processes, or what we call mycotic aneurysms, as well as vasculitis. Abdominal aortic aneurysm, or what is known as the AAA, is very important and is currently considered to be the most common type of aortic aneurysms. This aneurysm involves the abdominal part of the aorta. It can also extend into the common iliacs. The arch and ascending parts of the thoracic aorta can also be involved. Pathogenesis of abdominal aortic aneurysm. It's atherosclerotic in many cases. So in most of the cases, atherosclerosis is the underlying mechanism. This condition is more common in males. It's rarely seen before the age of 50. Atherosclerosis again is a major cause. Other contributors include hereditary defects in structural components of the aorta, as we said before. Marfan disease. In Marfan disease, there's a hereditary defect in fibrillin, which is a protein that is very essential for elastic tissue synthesis and maintenance. Anything that leads to altered balance of collagen degradation and synthesis can lead to this abnormality as well. This could be seen following local inflammatory reactions and because of the effect of the destructive proteolytic enzymes, just like the one we see with vasculitis. So this is the abdominal aorta, and this is the most common location for abdominal aortic aneurysms. Notice that the bulge in the arterial wall begins just below the level of the renal arteries, and it may extend down until we reach the common iliac arteries. So it usually begins below the renal arteries and is located anywhere there above the bifurcation of the aorta. It can be saccular or fusiform in shape, so again the shape does not mean anything beside mere description of the morphology. It may become very large in size. It may attain a diameter of 15 centimeters, and it can be as long as 25 centimeters in some cases. Under the microscope, the arterial wall, because atherosclerosis is the main underlying mechanism of this problem, we could see evidence of atherosclerosis, atherosclerotic plaques, advanced lesions of atherosclerosis, and thinning of the media. This aneurysm frequently contains a laminated mural thrombus. These are pictures of abdominal aortic aneurysms, and two types of complications that are seen in these pictures. Picture A shows a rupture in the wall of the aorta, and picture B shows us a large mural thrombus inside the lumen of the aorta. Symptoms of aortic aneurysms. Now, this depends mainly on the location of the aortic aneurysm. So, it contains an aneurysm in the thoracic part or in the arch of the aorta. It may lead to hoarseness of voice or chest pain. If the aortic aneurysm is within the thoracic part, it might lead to back pain as well. Dyspnea is also a very important symptom for the thoracic aortic aneurysm. For abdominal aortic aneurysms, the main symptom would be deep abdominal pain or discomfort or back pain, or a pulsating feeling in the abdomen. In many cases, however, the aortic aneurysms are asymptomatic. Besides clinical history and physical examination, it should also involve the use of radiology. So this is an ultrasound of the aorta that shows us that the diameter of the aorta. There's also through this هاي الطريقة بنعمل فيها measurement للabdominal aortic aneurysm diameters. The diameter is a very important prognostic measure that needs to be done for any aortic aneurysm. Also, CT angiographic images are very important in assessment as well as follow-up of these lesions. In this example, we have an aortic aneurysm involving the descending thoracic aorta with a considerable large mural thrombus here. So this bulge here is the distended or the dilated thoracic aorta. This is the color of the blood inside the aorta, and this area looks different. It has a different color, a darker color, because it contains a thrombus. This is the same. This is the same lesion from a different point of view to see that there's a significant bulge in the wall of the aorta, and this bulge contains a mural thrombus. Now, what are the clinical consequences of abdominal aortic aneurysms? Now, what are the clinical consequences of abdominal aortic aneurysms? The first and the most feared complication is rupture of the aneurysm, which leads to massive internal hemorrhage. The risk of rupture is directly related to the size or the diameter of the aneurysm. So aneurysms that have a diameter of more than 5 centimeters have a higher risk of rupture. The mortality for unruptured aneurysms is low in comparison. If rupture happens, mortality rate rises to more than 50%. The second consequence is obstruction of downstream vessels leading to ischemic injury of the affected organs. These pictures shows us mural thrombi inside a large aortic aneurysm. This one here is a thrombus. There's an extensive large mural thrombus that is almost occluding the whole lumen of the aorta. Again, this means ischemia of all the downstream tissues. Compression of an adjacent structure is also common, especially in large-sized abdominal aortic aneurysms. For example, the ureter could be compressed, or one of the vertebrae, leading to symptoms. An abdominal mass, often that is often pulsating, can be also in cases of large abdominal aortic aneurysms, like the one you can see here. Now, moving into some special terms about aneurysms. Mycotic aneurysms means that the presence of infection of an artery that weakens its wall, leading to abnormal dilation and an aneurysm formation. This infection could originate from either an embolization of a septic thrombus, like for example what happens following infective endocarditis, or the infection could be an extension from adjacent suppurative process, or there are some circulating microorganisms that will go and infect that arterial wall. Another important type of aortic aneurysm is syphilitic aneurysm. Now, you know from microbiology lectures that syphilis is a sexually transmitted disease that has 3 stages, right? Primary, secondary, and late or tertiary stages. Now, syphilitic aortic aneurysms are something that is related to the late or tertiary stages of syphilis only. Syphilis is a sexually transmitted disease that is caused by the spirochetes Treponema pallidum. Now, development of complications following syphilis are rare nowadays thanks to the rapid recognition and treatment of syphilis by antibiotics. Those unlucky patients who progress to reach the tertiary stage of syphilis can develop as a complication something we call obliterative endarteritis, which is some sort of vasculitis involving the vasa vasorum of the aorta. This inflammation of the vasa vasorum of the aorta will lead to ischemic injury to the media of the aorta, and consequently the media will become weak, leading to bulging and dilation of the aorta. The most important parts of the aorta that are involved by this process are the aortic annulus and the ascending part of the aorta. That's why it might lead eventually to valvular insufficiency, aortic valve regurgitation. Now, a different term that we are going to discuss now is dissection. So what is the difference between an aneurysm and a dissection? In dissection we have extravasation of blood through a tear in the intima. So because of the presence of this intimal tear, the blood flow inside the artery that is involved by dissection will go into the true lumen plus inside the false lumen, which is caused by the injury or the dissection. And this false lumen is within the layers of the media of the artery. So again, arterial dissection is an extravasation of blood that enters the wall of the artery through an intimal tear, as a hematoma dissecting between its layers. Often, but not always, this dissection is aneurysmal, meaning that the wall of the artery is originally, in many cases, dilated and abnormal. Both true aneurysms and false aneurysms and dissections can rupture. So all types of those vascular lesions we are discussing today, including true aneurysms, false aneurysms, and dissections, all of them can have rupture as a major complication with its catastrophic consequences to the patients. Aortic dissection, again the aorta is a very important vessel to talk about dissection there. Any part of the aorta can be affected by this dissection, descending the arch, thoracic and the abdominal aorta. And this is actually a catastrophic event whereby the blood dissects apart the media to form a blood-filled channel within the aortic wall. Complications are very important and include massive hemorrhage, cardiac tamponade in case of hemorrhage into the pericardial sac. So in this diagram we have representation of the progression in the aortic dissection. So at the onset of dissection there's only a tear inside the intima through which the blood will go inside the media, and from there it can go and have different directions of the blood. Remember that the blood in this location is moving under very high pressure, so it will start to collect very rapidly inside that location, and with time, with progression of the dissection, the blood will fill the false lumen that is forming inside the media. A large amount of blood that should remain inside the blood vessel, should remain inside the aorta, is moving out of it, and we are losing this part of the intravascular compartment. Now, what are the causes of aortic dissection? Hypertension is the major risk factor in this, and this is directly related to a pressure-related mechanical injury and or ischemic injury to the arterial wall. Another important mechanism is inherited or acquired connective tissue disorders that lead to abnormal vascular extracellular matrix. For example, Marfan syndrome, Ehlers-Danlos syndrome, vitamin C deficiencies, copper metabolic defects. Marfan syndrome, just a few words about Marfan syndrome. This is the most common among inherited or acquired connective tissue disorders that are associated with aortic dissection. It is caused by an autosomal dominant defect in fibrillin. Fibrillin is an extracellular matrix scaffolding protein that is required for normal elastic tissue synthesis and maintenance. Manifestations of Marfan syndrome involve skeletal abnormalities, for example, elongated axial bones, some ocular findings, for example, lens subluxation, and most importantly, cardiovascular manifestations, including aortic dissection. Manifestations of aortic dissection include sharp chest or back pain, weak pulses in downstream arteries. If rupture happens into the pericardium, that might lead to cardiac tamponade, blood pressure difference between the right and left arms in cases of proximal aortic dissection lesions, hypertension because of the internal hemorrhage that is happening, and consequently shock. Diagnosis and clinical assessment of aortic dissections depend on proper history taking, physical examination, as well as the use of radiology images. So in this chest X-ray we can see that the shadow of the heart is large and there is widening of the aortic shadow. Transesophageal echocardiogram is also helpful to assess the presence of the false lumen. Clinical assessments also involve or comprise the use of radiology techniques. For example, simple X-rays, chest X-rays, transesophageal echocardiograms, magnetic resonance angiography, and CT angiography. This is a contrast-enhanced CT images showing aortic dissection, indicated by this arrow here. Okay, and at the same location, using a different point of view, we can see the aneurysm of the descending aorta here. So this is the false lumen. This is the actual lumen of the aorta, and this here represents the false lumen of the dissection. So in cases, as we said, of aortic dissection, the blood will go through the intimal tear, and it will move into different directions under very high pressure. If we take a microscopic section through an aortic dissection and using some special histochemical stain, including silver stains, that shows us elastic fibers in black color. So these black lines are elastic fibers within the media of the aorta. So this layer is the media because it contains this black layer, the elastic fibers. And in this area of the media we have a defect. We cannot see any black lines here. So the black star here represents the blood that is dissecting through the media. Aortic dissections are generally classified into two types, type A and type B. Type A dissections are more common, more dangerous, and they are proximal to the takeoff of major aortic branches. It involves either the ascending aorta only, or both the ascending and descending parts of the aorta. And these represent types 1 and type 2 of Debicki classification. This is another classification, an older classification of aortic dissections. Type P dissections, they occur distal to the takeoff of major aortic branches. It does not involve the ascending part of the aorta. It usually begins distal to the subclavian artery. They are also known as Debicki type 3. Previously, aortic dissections were typically fatal, but the prognosis has markedly been improved thanks to rapid diagnosis and institution of treatments. Treatment of those cases depends on the clinical assessment of the patient, the use of antihypertensive therapy at the right time, and of course surgical procedures that involve plication of the aorta and wall reconstruction with synthetic grafts.